I thought about starting from what the ancient Greeks believed. Galen believed that disease was caused by an imbalance in bodily humors. And these humors, blood, black bile, yellow bile, or phlegm, these humors were actually bodily substances. They were produced by organs in the body under the control of things that could be influenced by things such as diet or activity or breathing. And the idea was that the production of these bodily substances had to be carefully regulated. The point is that disease was caused when there was an imbalance in bodily substances. And what's interesting about this theory is that it was the predominant theory of disease causation in the world for 2,000 years. That really stayed as the dominant theory of disease until the time of Pasteur and Billroth and Koch and the emergence of Pasteur's germ theory of disease. In fact, the humoral theory of disease and the humoral practice of medicine is still actually an active body of work in the Far East. In Indo-Tibetan Buddhism, doctors, for instance, practice humoral medicine based largely on these ideas of balancing the production of bodily substances. But in the West, there was a relatively rapid adoption of Pasteur's germ theory of disease. And recall, Pasteur didn't say all germs were bad. Pasteur said that some germs can cause disease. And from understanding that, it really became possible to start to think about diseases that were caused from agents outside the body, not from agents inside the body. And really, that concept of approaching disease as a problem of infectious agents was the predominant theory of disease causation up until fairly recently. In fact, the idea that the immune system could prevent these germs or prevent these infections in Pasteur's own work on vaccinating a child against rabies really congealed the thinking that the immune system had to be mobilized to prevent the damage that the germs caused. Throughout history, there were, as you know, recurring episodes of Black Death or plague or pestilence, as it was called. Nearly 20 million people died in perhaps one of the most famous outbreaks of the plague in the 14th century, which represented a third of the population of Western Europe. But if you look at the disease that occurred in the 14th century, there were really two different forms of it. One form was the bubonic plague form of the disease, which was characterized by fever, flu, sneezing, rash, lymphadenopathy, and a relatively high mortality, but it was not uniformly fatal. It was 35 to 70% mortality even back in those days. The course of this disease would play itself out over 5 days to 2 weeks. The other form of the disease, the septicemic form of the disease, was characterized by fever, acute shock, necrosis of hands and feet, and 100% mortality, often within 24 to 48 hours. These were two very different disease syndromes. And of course, at the time, the pathogenesis was completely unknown, and it was called a pestilence. I would point out that the hand looks strikingly like what you can see in the emergency room of many major medical centers, even today, as a consequence of another acute shock lethality caused by, in this case, meningococcemia. So in grappling with what was causing this, a Jesuit priest, Father Kircher, wrote in the 17th century that the pestilential poison was driven by the heart into the liver and the rest of the body to spoil such weak and ignoble members with a harmful inflammation. Then the poison rages within, conquers the entire body, and overwhelms him, and finally brings about death. It's interesting to think now with what we know about harmful inflammation, and whether the good Jesuit was prescient or not would probably be beyond the scope of my ability to know at this time. Nonetheless, after the general acceptance of the germ theory of disease, in the 19th century, there was an outbreak of plague near Vietnam. And actually, this caused two separate investigators, Yersin and Kita Sato, to basically rush to Vietnam to try to be the first to identify the plague bacillus. And in fact, they competingly discovered the causative agent of plague, Yersinia pestis, which was named in honor of Yersin because he documented his case better and published in a better journal. There's a lesson there. And of course, now this really placed the final emphasis on the fact that diseases are caused by bacteria, and eventually with the development of antibiotics could be treated as such, even one as bad as the pestilence or the plague. Today we have another pestilence, and it's sepsis. And the numbers are staggering, whether it's by annual cases, the mortality, or cost. But sepsis is a syndrome, not a disease. In its highest grouping, it's defined as a systemic inflammatory response to infection or injury. You don't have to have infection, characterized by abnormal temperature, heart rates, respiratory rates, and white blood count. If you run around the block, you clinically have sepsis. That's a big problem if you're trying to do clinical trials. Severe sepsis, on the other hand, are those findings, including signs of organ damage, such as hypoxemia, oliguria, lactic acidosis, and altered cerebral functions. Severe sepsis is the syndrome which creates those big numbers, not all sepsis. All sepsis would include things like common cold and physical exertion. Septic shock is another clinical syndrome, which includes hypotension, increased fluid requirements, respiratory failure, pulmonary edema, diffuse bleeding, and tissue injury. And these are not necessarily progressive things. One can have one syndrome without the other, and they can come in different sequences and orders. But suffice it to say, I think we all agree the pathogenesis of severe sepsis is unknown. My colleagues and I in the early 80s were very interested in looking at the syndrome of severe shock and asking, could this problem be caused by an overproduction of cytokines? And in fact, it became quite clear working at Rockefeller and Cornell that administration of a single cytokine, TNF, was sufficient to cause a clinical syndrome, a physiological and pathological and hemodynamic syndrome that was indistinguishable from acute septic shock. And that's shown in the experiments in which a rat was infused with recombinant human TNF, and within minutes, the animal went into shock and died. A necropsy of that animal showed hemorrhagic necrosis of tissues, not significantly different than the example I showed you of the necrotic hand. And the treatment model figure is also the sort of clinically relevant therapeutic experiment in which we treated baboons with lethal bacterial infection here caused by E. coli. We treated them with monoclonal anti-TNF antibodies and showed that these antibodies prevented the development of lethal acute shock in this model of acute septic shock, not sepsis. And what's important here is this was the first example that you could really dissociate the disease, acute septic shock, from the presence of the bacteria, because all of the baboons had replicating bacteria in their bloodstream at 6 and 7 hours after the infusion, meaning that the bacteria weren't the disease. The mediator, TNF, was causing this particular disease syndrome. And I hasten to add to those of you who are new to the field of sepsis, seeing all these animals that are cured, at this time, nothing cured any of these animals. And it's really amazing to me that once there's an acceptance that you can treat a complex problem with one particular approach, that there might be other molecular or specific approaches that also work. And clearly, we use this as an example of a cytokine that can cause a disease and can represent the basis of treatment for a disease, but it's not the only cause of the only disease. That said, I know of no other mediator, cytokine or otherwise, that causes acute shock, hemorrhagic necrosis, and pathological signs that are indistinguishable from acute septic shock. There may be some to be discovered, but to my knowledge, TNF's the only one still for that syndrome. As you know, the anti-TNF antibodies are now clinically approved. It's interesting. Another theme we have seen is the development of early work on acute shock, or acute septic shock in this case, led ultimately to drugs that are clinically approved for the treatment of rheumatoid arthritis and Crohn's disease. And these agents have significantly improved the quality of lives of literally millions of people now. So significant advances in rheumatoid arthritis, psoriasis now, colitis, probably other diseases are based on early work, not from any of those diseases, but from sepsis in some funny way. It's quite likely that the first clinical uses for many of these molecules will not be in sepsis. They'll be in other diseases. And that's yet another problem for the Sepsis Alliance. Sepsis trials are expensive, difficult, and likely to fail. Making the point again, severe sepsis is not septic shock. Severe sepsis runs its course over many days or weeks. Acute shock can occur acutely. Anti-TNF, now in multiple animal models, from baboons to humans to small animals, protects animals from septic shock, but in the animal models of sepsis we've been talking about, the anti-TNF almost uniformly makes them worse. TNF levels, even in patients who are in large clinical trials with sepsis, are low or non-detectable. It makes it difficult, even now 15 years later, to draw scientific conclusions about whether TNF has any role in severe sepsis, although the animal data argues against it. The pathology of TNF infusion in animals is very different than the pathology of HMG infusion. When you infuse TNF in animals, it causes significant inflammation, myocarditis, vasculitis, necrosis in tissues, and inflammatory damage in the brain. You can kill animals with other cytokines like MIF, IL-1, or HMGB1 and see almost no pathology. And in fact, when humans die of severe sepsis, oftentimes you find virtually normal tissues on pathology. They don't have hemorrhagic necrosis. They don't have widespread inflammation. They don't have endothelial damage. If you look hard enough, you can find some apoptosis in the liver and spleen, but there's basically a paucity of cell death in the somatic tissues. This sort of thinking led Haichao Wang and Wan Yang and others to look for other mediators of severe sepsis that did not cause shock. HMGB1 is one such mediator. Work from Wan Yang's paper in the PNAS shows that you can inhibit HMGB1 and prevent the lethality of lethal sepsis. Interestingly, like TNF, there are parallel preclinical developments of these antibodies for rheumatoid arthritis trials and or other trials of autoimmune diseases. This is based in part on work we did in collaboration with Ulf Andersson and Rico Kokkola at the Karolinska, which shows that the disease is significantly abrogated or attenuated by administration in the blue line of either anti-HMGB1 antibodies or in the yellow line of an A box, which is an HMGB antagonist. The number of clinical targets of HMG inhibitions are growing. The list now includes stroke and colitis. Recently, a Japanese group showed a highly significant clinical remission from DSS-induced colitis by treatment with anti-HMGB1 antibodies. I think clinicians here would accept that patients can arrive in the emergency room or the ICU in an acute shock state, as occurs, say, with fulminant meningococcemia, and they can either live or die. If they live, they can go on to develop severe sepsis. They can present with community-acquired pneumonia, an HMGB1-like syndrome or an MIF or IL-1-like syndrome, and then go on for a long time and live or die without ever going into shock. Or they can go on for some period of time and then develop a second problem of acute shock. By thinking in terms of individual cytokines and individual clinical scenarios, one can begin to construct ways of diagnosis and designing of future treatments. We presently spend in every major medical center and every ICU millions of dollars a year precisely characterizing individual strains of bacteria and then treating the patient with broad-spectrum antibiotics that kills it all. We don't know how to do this yet, but this is where we need to be. We need to be thinking in the future about how to assign a particular disease syndrome to a particular patient with a particular genotype expressing a particular amount of cytokine receptors to a particular stage in their disease where that one cytokine or another is perhaps predominant in the clinical effects. I don't know how to do that now. It's an enormously expensive problem. It's achievable with an enormously extensive body of work. It's doable. I think we need to be thinking of it in that way. Said slightly differently on this balance question, severe sepsis results from lots of different events, a car accident, pneumonia, or even as a consequence of ischemic damage to an organ. And what these things have in common in the yellow stars, these patients can look extremely different when they come to the hospital. But they all have in common the fact that they activate the innate immune system to make cytokines, which in the overwhelming majority of cases leads to the recovery of the patient. The problem occurs when the cytokine production or activity begins to sort of proceed disconnected from the inciting event and unregulated. And in that case, I've got my two favorite cytokines here. You can add yours. I don't feel territorial about this. I think this is a multi-cytokine problem. The problem with putting all the other cytokines on is that the list would be enormous. There'd be 50 or 60 mediators on this list. The point is 50 or 60 different cytokines have now been implicated as having sort of discrete clinical, physiological signs and symptoms associated with their activities and have been inhibited in different animal models of inflammation or disease, which then treats the disease at some level or other. The question is, how can this be regulated? And I'll spend the remaining few minutes talking about the fact that the nervous system can actually regulate this switch by sending signals down to the cytokine-producing cells to regulate their production. And this has opened another way of thinking about therapeutically developing agents to control this switch between beneficial and damaging amounts of cytokines. The mechanism is sending nerve signals down the vagus nerve to the organs of the reticuloendothelial system. And it was known previous to our work that the vagus nerve can detect the presence of inflammatory mediators and that this is required to activate a fever response. So if one injects a small amount of IL-1 into the abdomen of a rat, it causes a fever. But if you cut the vagus nerve, there's no fever. What we've showed is that driving a signal down the vagus nerve the other way into the immune system turns off cytokine production. The way it works here in the acute shock model, the TNF model, is if you apply a vagus nerve stimulator to these animals, they don't go into shock and they don't make TNF. So these are animals given endotoxin, they make TNF in the blood. If you cut the vagus nerve, they make more TNF. If you electrically stimulate the vagus nerve, they are protected. They don't make TNF and they don't go into shock. And this was work done by Ludmila Borvikova here some time ago when she was a postdoc. This is true for the acute shock model of TNF. It's also true for the more chronic severe sepsis model, cecal ligation and puncture, based on HMG inhibition. So this is work done by Jared Houston, who's a surgeon at Cornell, who spent 3 years here in the lab. And what Jared showed is if you stimulate the vagus nerve, you decrease HMG levels in the CLP model and prevent death. So we can now think in terms of the fact that there's this neural regulation of inflammation. Stimulating this regulatory system can lead to the reduction of cytokines and improvement of outcome. And obviously, we were curious about the molecular side of this because this represents a drug target. So the target turned out to be this molecule, which is the nicotinic acetylcholine receptor called alpha-7, and it's a homopentamer, 5 subunits. which bind acetylcholine or drug at one of 5 sites shown at these junctions. It looks like a donut, and this is a ligand-gated ion channel that allows cations to go into the cell through the membrane. And if you turn this thing on its perpendicular axis, you can see that it forms this channel, which allows cations in. Very little is known about this molecule in macrophages, but we and others here and now in laboratories around the world have shown quite convincingly that agonists of this receptor inhibit cytokine release. It's interesting also to think in terms of the intact animal. In fact, the signals through the vagus nerve require this protein. And this surprised us because there's lots of proteins in animals and in humans that bind acetylcholine, but this one is absolutely required for this effect. And the proof of that is from normal wild-type mice. You give them endotoxin, they make TNF. You vagus nerve stimulate, it's blocked. But if you knock out the alpha-7 receptor, now you see they make more TNF in response to endotoxin, and the vagus nerve stimulator doesn't work. This really surprised us because we presumed redundancy in the signaling pathway would mean that multiple genes would be involved. But what this says, and this is work from Hong Wang, who was a postdoc in the lab and now has her own lab down in Philadelphia, what this paper says is that this single gene product is absolutely required for the functional integrity of this physiological pathway. Mauricio Rosas, who's a graduate student here at the Feinstein, has spent the last several years working on his thesis to develop the idea of where this is occurring, and he's traced the nerves that carry the signal to the immune system to these very small nerve endings in the spleen. So it's very interesting to think in terms of the fact that signals originating in the brain can travel all the way down to a single cell to control the production of a cytokine like TNF. We and others have now used this in therapeutic models of either vagus nerve stimulation or highly selective alpha-7 agonists to treat animals with disease. We're not trying to cure mice, so we've cured a lot of them. We'd like to move all of these into the clinic. Right now, the list includes endotoxemia, sepsis, arthritis, hemorrhagic shock, ischemia, reperfusion. And this is an important one because this was an aortic cross-clamping model, which is done basically once or twice a day in 50 to 100 major medical centers in the United States for aortic and thoracic aneurysm surgery. These people, when the clamp is removed, they go into shock because they overproduce cytokines. And the idea would be, can one apply the vagus nerve stimulation to those patients on a compassionate use basis? Subcutaneous inflammation is another model of arthritis, the one that Christine Metz talked about. Pancreatitis, autoimmune diabetes, ileus, colitis, and bleeding. A lot has happened since the acceptance of the understanding that cytokines are both necessary and sufficient to cause disease, and they can be validated by either administering cytokines in humans, which causes disease syndromes, or by blocking cytokines in humans, which removes disease signs and symptoms. And now we can think in terms of either targeting the cytokines directly with antibodies like Enbrel or Remicade, and hopefully future antibodies being developed like anti-MIF, like anti-HMGB1. But we can also think in terms of pharmacological approaches. Valentin Pavlov has shown recently, using a highly selective alpha-7 agonist choline, that he can selectively inhibit both the shock syndromes and the sepsis syndromes in animals, and that paper is under review. He's also showed in a paper that he published in the Proceedings of the National Academy of Sciences last year that muscarinic agonists administered either into the brain or into the periphery where they can travel to the brain can activate outgoing pathways down the vagus nerve to block inflammation in the periphery. That's very exciting. Lastly, it's fun to think about where to go from here. If I had all the money in the world to do a research project, I would like to work with my colleagues here to figure out what does the map look like. The nervous system somatotopically organized. Most of us can walk and chew gum at the same time, play the piano and drink a glass of water, that kind of thing. And that's because different brain regions control different body parts at different times and under different networks. And the question now is, if the nervous system is somatotopically organized to do that, and if the nervous system is somatotopically organized to control heart rate and renal perfusion and other visceral functions, doesn't it make sense, or isn't it a reasonable hypothesis that the immune system is also somatotopically organized to control various components of the immune response? And are there regions in the brain, or perhaps not in the cognizant cortical regions, but deep-seated regions in the brain that control cytokine production in different body compartments, that control the timing of cytokine release, that control how dendritic cells mature, how regulatory T cells are expanded or contracted, and how B cells might be cloned or respond to stimuli? So this is where I would go given my druthers. And with that, I'll say thank you.